Hello, my dear future nursing officers. Welcome you all to the Master Nursing classes. So, in the today's very important video session, we are going to discuss a very important and the golden points chanting for our upcoming Norcet exam and any other state and central government exam. So, here in this particular video, my thing is very clear, that is to give the high yield content, important content, and the golden point chanting and revision. So I want everybody of you to work hard along with me, and whatever the content I am giving, so please work on it. And wherever I am telling it is important, so please pay the special attention on that particular things and note it down and at least revise one or two times. Yes, a very good evening to the one and all who are attending the live session. Good evening, beta. Very good evening to one and all. So please hit the like button. Okay, so first thing, when entering to the class, you have to hit the like button. Then after that, you have to enter the live chat. So it will be helpful for me to understand how many of you are attending the live session, right? So fatafat hit the like button, then enter to the. Yes, very good evening to one and all. Good evening, very good evening to one and all. So welcome you all once again to the Master Nursing classes. So where after attending the class, the students becomes masters here. Okay. So welcome you all once again to the Master Nursing class. So fatafat hit the like button. And if any one of you are watching the Master Nursing classes first time, so please subscribe to the channel and share the class with your friends. If any tutors, professors, anyone of you are watching the class, so please share this video with your students, so it will be helpful for your students to improve their knowledge also. Okay, so welcome you all once again to the Master Nursing classes, right? We will start the today's session. Can we start? Is that the video and audio is everything is clear to every one of you? So fatafat do a thumbs up in the live chat. Is that clear? Well done. So we will start the session now without wasting us time, because we have the very less time, and the time which is remaining is a gold for us. Okay, so now the time with what we are having, which is the a golden time. Okay, so every second matters here for your rank. Yes, so today's class will go somewhat lengthy. Okay, for the duration of the 1.5 to 2 hours it may extends, because the whatever the content here I am covering, which is important, so please stay connected till the end of the class. Okay, so wherever I am telling it is important, work on that one, please. It will be helpful for you all, right? Yes, so we will start the today's session with this powerful motivational line. Students, whatever the thing you want to do now, whatever the plan you have planned, so that one, if you want to do on, if you want to work on that one, yes, implement it now. Why? Because sometimes later what you will say, and whatever the thing you are postponing, so that it becomes never, right? So do it now, because this is the perfect time, this is the good time, and this is the time to prove yourself, right? So if you want to achieve something, so never say later, so say now and do it now. Okay, so that will be a very beneficial, and that is the a strategy followed by the lots of the champions, right? So without wasting the time, we will start the today's session with this powerful motivational line. Say now. Okay, connect the video till the end and don't leave the session in between, complete it till the end. Okay, so then you can do whatever the thing you have to do. Okay, so let's begin the session, and here is the first question, awaiting for your excellent answer in the comment box. So I want everybody of you to put the correct answer in the comment box now, right? What does the fetal station +3 indicates during the labor? What do you mean by a fetal station? That is the +3, which is indicating during the labor. Yes, option A, that is the fetal head is 3 centimeter above the ischial spine. Option B is the fetal head that is the at the level of the ischial spine. Option C, that is the fetal head is 3 centimeter below the ischial spine. And option D, the fetal head is has not yet engaged in the pelvic cavity. So what is the correct answer? I'm waiting for your brilliant answer. So what do comment in the comment box. Well done, beta, well done. So this is the consistent correct answer makes you a champion. Remember the 3 C's. That is the consistency, correct answer. That is a way of the becoming the champion, right? Right. Well done, beta, well done. So here the first answer goes also as a C. Okay, so that is the very important. +3 station means that is which is 3 centimeter below the ischial spine. Sir, what is the actual real concept behind this one? Beta, understand this particular image you have to see first. So here posteriorly we have the a protruded bony prominence of the pelvis. So this protruded bony prominence of the pelvis I call this one as in the ischial spine. What I call this one as in the, I will call this one as in the ischial spine. Okay. So if the fetal head at the level of the ischial spine, means the fetal head is at the zero station. Okay. So fetal head is now at the zero station. If the fetal head is 1 centimeter above the ischial spine, means it is in the -1 station. If the fetal head is 2 centimeter above the ischial spine, means that is the -2 station. Fetal head is 3 centimeter above the ischial spine, that is the -3 station. Students, every minus thing means which indicating the fetal head is above the ischial spine, and which is above means it will be in the minus. If the fetal head which is crossed the ischial spine and which came 1 centimeter below the ischial spine, means that is the +1 station. If the fetal head which crossed the ischial spine which came the 2 centimeter below the ischial spine, means that is the +2 station. If it comes 3 centimeter below the ischial spine, that is the +3 station. Okay, so very important. At the level of the ischial spine, 0 station. Above the ischial spine, minus station. Below the ischial spine, plus station. 1 centimeter above, -1 station. 2 centimeter above, -2 station. 3 centimeter above, -3 station. 1 centimeter below, +1 station. 1 centimeter, 2 centimeter below, +2 station. 3 centimeter below, that is the +3 station. In the question, they have asked what you mean by the +3 station. That is the fetal head is 3 centimeter below the ischial spine. This goes to the correct answer. Hope every one of you are very clear about the fetal station. And I want to tell some golden point about the ischial spine. So this ischial spine is the very important anatomical landmark. Okay. This ischial spine is a very important anatomical landmark here. So we will use this one first to determine the station of the fetus. Okay. So we will use this one to determine the station of the fetal head. Okay, where the fetal head is like landing in the female uterus and in the female pelvis. To say that one, we will use the ischial spine. Okay. So another very important thing, we will use this one. Okay, the ischial spine is the area where we will give the pudendal nerve block. Pudendal nerve block. So this pudendal nerve block, when we have to do, whenever we are doing the instrumental delivery, we have to insert some instrument inside the vagina. So that time there will be a heavy pain will be created. In order to prevent the pain due to the very important instrumental delivery, that time we have to give the pudendal nerve block by using the local anesthesia 1% of the lignocaine. So at that particular time, where we have to give the injection, we have to give the injection at the level of the ischial spine. Remember, the pudendal nerve block injection will be given at the level of the ischial spine. Very important second point. Okay, so in the second stage of the labor, we will study the cardinal movements of the fetus. Means fetus while coming out of the uterine cavity to outside, so it will gone through the various movement like external rotation, internal rotation, okay, flexion, descent. Okay, so various cardinal movement will happens. In that one, there is one very important cardinal movement, that is the internal rotation of the fetal head. So where the site of the pelvis, where the internal rotation of the fetal head happens, means that is the internal rotation of the fetal head happens at the level of the ischial spine. Very important golden point. Remember. Okay. So internal rotation of the fetal head. Internal rotation of fetal head happens at the level of the ischial spine. A very important concept. Okay, so these are the important concept related to ischial spine. So don't forget this one because it is the very important one. Okay, so and one more important point, remember, that is the a very important muscle which is there in the pelvic cavity of the female, that is the levator ani muscle. The levator ani muscle also located at the level of the ischial spine. Remember. Okay, so it is a site of the where the levator ani muscle will located. Okay, levator ani muscle is located at the level of the ischial spine. Internal rotation of the fetal head happens at the level of the ischial spine. Pudendal nerve block we have to give at the level of the ischial spine, and station will be determined in reference to the ischial spine. Okay, so hope these all golden points are very much helpful for every one of you, and the concept behind the ischial spine and the fetal station is very much clear to every one of you. Yes, is that clear? Yes. So the next question is here, and it is awaiting for your brilliant answer in the comment box. So I want every one of you to answer whether it may be a correct, whether it may be a wrong, because if it is wrong, I will correct you and I will teach you and I will clear your concept if it is right, and all the best from my side, right? So yes, do mention your comments in the your answer in the comment box. So what? Which of the following drug is used as a, or which of the drug we can used in a painless labor as in the epidural analgesia? So here we are talking about the painless labor and epidural analgesia. Okay, so very important concept, right? Which of the following is on the drug of choice in the painless labor, that is in the epidural analgesia? Option A, oxytocin. Beta, if you are giving the oxytocin, means it will increase the uterine contraction. Uterine contraction increases means pain will increases. So oxytocin never be used as in the painless epidural analgesia, eliminating the option A. Then magnesium sulfate, yes, in the preterm labor conditions, we are giving that one to mature the fetal brain, and in the severe preeclampsia and eclampsia, we are giving that one to prevent and treat the eclampsia and seizure. Okay, so that is the magnesium sulfate is not used in the painless labor. So I am eliminating this particular option D also. So option C, the prostaglandins. So prostaglandins, here we have the prostaglandin E1, F2 alpha and E2. Okay, so among these E2, prostaglandin E2, that is the carboprost 1. So that one used for the ripening of the cervix and induction of the labor. Okay, it will be not used in the painless labor. So I am eliminating the prostaglandin. And among these prostaglandin, I told E2 is the prostaglandin. Okay, so there is the prostaglandin E2 carboprost 1 only used for the ripening of the cervix and induction of the labor. Okay, so another two prostaglandins, prostaglandin E1 and prostaglandin F2 alpha, both are used in the prevention and treatment of the postpartum hemorrhage. Okay, so these are not used in the painless labor. The drug of choice for the painless labor and the epidural analgesia is our bupivacaine, and almost all you people have given the correct answer for this particular question, and I am very happy for your dedication, your consistency, your preparation, because the near the exam you people are giving the answer very confidently. This will be makes me happy, as I am very happy about my students. Okay, so well done beta, very good. Okay, so here is the some concept behind the painless labor. Okay, so try to understand the concept, why pain happens in the labor. Why pain happens in the labor? Pain in labor. Pain in early stage, which is happening due to the uterine contraction. Due to the uterine contraction. So that time the nerve root involved here is that is our T10 to L1. Okay, so pain in the late stage. Okay, so pain in the late stage, this is happening due to the cervical dilation. Okay, this is happening due to the cervical dilation, and the nerve root involved here is the nerve supply of the cervix. That is the very important S2 to the S4. Okay, so these are the nerve root involved here. Okay, so in order to prevent the pain during the labor, so we have to give the epidural analgesia. Look at the question. Here they have not mentioned the anesthesia. This is the analgesia. This is the analgesia, means it will decreases only pain, it will be decreases. Okay, no effect on the uterine contraction. Okay, no effect on uterine contraction. So uterine contraction will happen regularly as usual. Okay, but only pain will be decreased here. So this is what you call as the painless labor by giving the epidural analgesia. Okay, so in case of the analgesia, if you are giving the anesthesia, means it will block both the motor and sensory. So due to the blockage of the sensory functions, it will reduce the pain, and due to the blockage of the motor function, it will reduce the uterine contraction also. So in the analgesia, only sensory portion will be blocked here. Okay, so there is no any blockage of the motor function. So uterine contraction will happens normally as usually, and only pain will get decreases here. Okay, so only pain will get decreases here. Hope it is clear to every one of you. Yes, sir. Sir, the concept we have come to understand here. Okay, so late stage the pain is happening due to the cervical dilation, and in the early stage the pain is happening due to the uterine contraction, and the nerve root we have understood it we have started from the T10. Sir, what is the site of administration of the epidural analgesia? And I told the root, so the root is always, I told, that is the epidural. Okay, so we are giving this one in the above the dura mater. Okay, so you know the three layers of the meninges: S dura mater, then pia mater, then the arachnoid mater. So outermost meningeal layer is the dura mater. So epidural means we are injecting through the spinal canal, and we are going till the epidural. Okay, so above the epidural only. Okay, we are not breaking the meningeal layers. So above the outermost layer of the meninges, that is the epidural. Above that one only we are giving the analgesia. Okay, so that is what we call the epidural analgesia, right? So we have to give this one, and the epidural analgesia will be given in the painless labor. Okay, remember this one is the trending topic, so the question may comes here. Okay, because in most of the private sectors, almost all women they are preferring for the painless vaginal delivery, because that is the reason it is the trending topic in the OBG, so it will strike in your exam. So I'm explaining this one in detail, in perfect, in sweet and short, so that is much necessary for your exam. Okay, so painless vaginal delivery. Okay, so we have to give the epidural analgesia. Epidural analgesia. So drug of choice I have told already, that is the bupivacaine. Okay, so the drug of choice is the bupivacaine, and site is at the level of the T10. Very important. And remember, as a nursing officer, you are taking care of the patient where you have given the epidural analgesia. So there is sudden decrease in blood pressure will happens. So always and always, whenever you have taken care of the patient with painless vaginal delivery, after the administration of the epidural analgesia, you have to check blood pressure. You have to check blood pressure once in every 15 minutes. Okay, so once in every 15 minutes we have to check the blood pressure. So this is the standard guidelines. Remember, very important thing. Okay, so hope it is clear to every one of you, right? So yes, these are a very important golden point where you have to understand. Okay, in the painless vaginal delivery, epidural analgesia will be given. That is the bupivacaine is the drug of choice. Site of administration at the level of the T10, and it will block all the followings. Okay, so there is no pain by the cervical dilation, there is no pain by the uterine contraction, but the contraction will be keeps on happening. Okay, because we are giving the analgesia here. Okay, not anesthesia. Hope it is clear to every one of you, right? So here is the next question in front of you all. So first, do mention your answer in the comment box. It is important. Yes. In which situation is the pudendal nerve block most commonly used during the instrumental delivery? Already explained the concept. Just you people have to read the options carefully, and whatever the thing I have explained, just try to implement in this question. The answer will be yours. Okay, if you are giving the correct answer, you will give the correct answer in the exams. You will give the correct answer in the exam means you will get qualified in the prelims, and you will get good rank in the mains, and I will take your interview, and we will upload same in this master nursing classes. Okay, so yes, how many of you are get ready for the interview? So please get ready now only. Okay, so immediately after the exams, you people just try to practice and prepare for the interview. Okay, so you have to share some big motivational thoughts to the upcoming aspirants, right? Yes, well done. So try to give the correct answer first for this question. Then after that we will talk about everything, right? So in which situation the pudendal nerve block most commonly used during the instrumental delivery? Better I told, while inserting the instrument inside the vaginal cavity. Okay, so after complete dilation of the cervix, we have to insert the instrument to pull the fetal head out in case of the difficult labor. Okay, so in that situation, there is a, like, if just we are taking one small needle and if I am pricking here means it will be painful for us, and it is very painful for us. Now I am taking the big, like instrument and inserting inside the vaginal cavity means it is very much painful. In order to avoid that painful, okay, so the nerve supply of the our pudendum, okay, so or the nerve supply of the our external and internal genital area I have to block here, and the mainly which nerve I have to block here, I have to block here the pudendal nerve, okay. So that is the reason at the level of the ischial spine I will give the 1% of the lignocaine, okay. So that is the what we call the pudendal nerve block, okay. So option A is telling here to provide the pain relief during the application of the forceps or the vacuum. Okay, so vacuum extraction in the second stage of the labor. So this is the main reason why we have to give the pudendal nerve block, okay, in order to avoid the pain during the instrumentation in the vaginal cavity, okay. So how we have to do the pudendal nerve block? So pudendal nerve block will be done like this, okay. So remember the golden points on the pudendal nerve block, okay. Pudendal nerve block. Okay, so here the drug of choice is 1% is lignocaine, right? Site of injection, already we have discussed at the level of ischial spine. Very important, keep in your mind, okay. So these are the golden points on the pudendal nerve block you have to keep in your mind, okay. Just we have to do this one, pudendal nerve block done before the instrumentation, okay, before instrumental delivery, okay. So very important, keep in your mind, right? So hope the concept is clear on the pudendal nerve block. Yes sir. Sir, what we have to do in the LSCS case, sir? Okay, so in case of the lower segment cesarean section, beta, here we will not give the any local, okay. So here we have to go for the spinal anesthesia, okay. So here we have to go for the spinal anesthesia, very important, keep in your mind, okay. So that is why, because I am taking the surgical incision over the abdomen, okay, means I want to block the nerve supply of the peritoneum also, skin also, muscles of the everything of the lower uterine segment. So I have to block here. So that is the reason in the LSCS I will give the anesthesia. I will give the anesthesia. So if I am giving the anesthesia means, yes, so that is a sensory blockage will be there. Sensory blockage will be there. So no pain will happen. So, okay, no pain will happen, right? And along with this, motor blockage will be there. Motor blockage means no uterine contraction. No uterine contraction. Okay, so here we have to give the anesthesia at the level of, yes, where we have to give the anesthesia at the level of the T4. Okay, so remember the very important golden points here. Okay, so hope it is clear to every one of you. In the pudendal nerve, during instrumentation, pudendal nerve block at the level of the ischial spine, 1% is lignocaine. In the LSCS, anesthesia at the level of the T4. Okay, in the painless vaginal delivery, okay, epidural anesthesia, drug of choice bupivacaine, site T10, sudden decrease of the BP will be there. As a nursing officer, you have to check the blood pressure every 15 minutes. All the golden points are clear to every one of you. And now I am going to the next question. So please do mention your correct answer. Already discussed question. So I want your answer fadafat in the comment box, because this is already discussed question. Yes, only 3 seconds, 4 seconds, 5 seconds I will give. Yes, 3 plus 4 plus 5 seconds. How much second? Yes, 11 seconds. Okay, so just within 11 seconds try to give the answer for this question. Okay, already discussed one. Which of the following drug is most commonly used for the pudendal nerve block during the labor? During the labor, so we are doing the pudendal nerve block before before insertion of the instruments. So that is the 1% is lignocaine. I already have told to you people. Okay, lignocaine, that is 1%. Okay, so this one will be injected at the level of the ischial spine. Okay, so no more discussion, because already we have discussed a lot on this particular concept. Okay, so here is the next question. So this is your very important question. So please do read the question and give the correct answer for this particular question. Take your time. Take a deep breath, relax, then give the best shot. Yes, which of the following is best clinical sign which indicating true labor pain? Option A, irregular contractions relieved by the rest. Beta, if the pain mother is feeling, if that one is the true labor pain, it will not get relieved by the any rest. The true labor pain, it will not get relieved by the sedation. The true labor pain, it will not get relieved by the any administration of the enema. Even if you give enema, even if you give the sedation, even if you give the rest, so there is no any decrease in the pain if it is a true labor pain. If the labor pain, whatever the mother is feeling, if that one is false labor pain, means if you are giving the rest, the pain will decreases. If you are giving the enema, pain will decreases. If you are giving the sedation, pain will decreases in the false labor pain. So in the true labor pain, the pain will not relieved by the rest, sedation, and the enema. Remember the golden word. Okay. So option A is telling there is irregular contraction relieved by the rest. Better in the true labor pain, the contractions will happen regularly. It will not happen irregularly. First point I am eliminating, and it will not relieved by the rest. So I am eliminating the option A here. Okay. So option A got eliminated. Then comes the option B. Okay, it is the regular contractions with progressive cervical dilation. Yes, in the true labor, contractions will happen how? True labor pain, the contractions will be regular and rhythmic. It is not continuous. Regular, rhythmic with cervical dilation. Sir, what do you mean by the regular and rhythmic, sir? Let me clear your concept. So this is the uterine contraction. Okay, so then the uterus will get relaxed. Then here the uterine contraction will happen. Uterus will get relaxed, then the uterine contraction will happen, uterine will get relaxed. So this is the what we call as the rhythmic contraction of the uterus. So contraction will be there, then after that relaxation will be there, contraction will be there, then after that relaxation will be there, then the contraction will be there, then after that relaxation will be there. And here the in between the contraction, relaxation is most important. Okay, so during the second stage of the labor, we need to educate to the mother. Whenever the mother is feeling the contraction, that time we have to ask her to push the baby down. Okay, so that is the we have to ask her to feel the bearing down effect. Okay, so bearing down means she will do the bearing. Okay, like this she will create a pressure. Okay, so the pressure will be created or the bearing down will be done along with the contraction. Whenever the contraction will be there, that time she should do the bearing down effect. Okay, so whenever the relaxation is there, during the relaxation period, we have to ask her to get relaxed. Okay, during the uterine relaxation, we have to ask her to relax and ask her to rest and ask her to take breathe and relax. Again the uterine contraction will start, then again we have to encourage her to do the bearing down, because uterine contraction also pushes the baby and she is also bearing down. She is also pushed the baby will come easily outside without any loss of the extra energy from the mother. Okay, so that is the reason this education is must for the mother during the process of the labor. Okay, so this is what you call as the regular and the rhythmic contraction, relaxation, contraction, relaxation. But in the false labor pain, how it happens? So here it is irregular contractions, means it is happening continuously. Okay, so continuous, but it is mild form. It is not in the increased in the intensity. But our regular contraction, it will increases in the intensity. Okay, so here it is the small contraction, means here it will be somewhat big contraction. Then here it will be somewhat big contraction. Okay, so duration, intensity, it will increases in the true labor pain. But in the false labor pain, there is no increase in the duration, there is no any increase in the intensity. But in the true labor pain, whenever the uterus will contract, that time cervix will dilate. Okay, so whenever the cervix will get dilate, so there is a mucus plug which is there in the cervix. Okay, consider this one is the cervix. Okay, so this one is the cervix, and here the mucus plug will be there, which is mixed with the mucus plug, which is mixed with the blood. Whenever the cervix will get dilate, that time this particular mucus plug will come out. Okay, so mucus plug with blood which will comes out, we call this one as in the show. Okay, so we call this one as in the show. So show will be present in the true labor pain, but in the false labor pain, there is no uterine contraction, means there is no any like uterine contraction will be there. There is no any cervical dilation in the false labor pain, no cervix dilation, no show. Okay, so blood tinged mucus plug will not come out in the false labor pain. In the true labor pain, the blood tinged mucus plug from the cervix, it will comes out. So that is what we call the show. Show is the very important sign for the dilation of the cervix, and if the cervix is dilating, it is the true labor pain. Okay, so remember, regular contraction will be there along with the progressive dilation of the cervix. So this will classically indicates this is the a sign of the true labor pain. Okay, so the option C, mild contraction that stops with hydration. So this is not an true labor pain sign. Okay, then the option C, pain localized only in the lower abdomen. Beta, so in the true labor pain, what happens, the pain will start in the lower uterine segment or in the lower abdomen. Pain will start and the pain will radiate to the back and the pain will radiate to the thigh. Okay, so remember, in the true labor pain, pain will start at the lower abdomen and it will radiate to the back and it will radiate to the thigh. But in the false labor pain, pain will start at the lower abdomen, but it will be localized. It will be in a particular point only. It will not get radiated to the back. It will not get radiated to the thigh. Remember the pain distribution in the false labor and true labor pain. Okay, so hope it is clear to every one of you. So I'm eliminating the option D also, then the option C also I'm eliminating. So correct answer for this question goes to the our option B. It is a regular contraction and it is a rhythmic contraction and which happens due to the progressive cervical dilation. Okay, so here are the standard very important quick revision table for your false labor pain and the true labor pain. So please do read the particular difference between the true labor pain and false labor pain. Already I have explained to you. Okay, so contraction pattern in the true labor pain, which will happens regularly and it will happens rhythmic and it is happening with progressive cervical dilation. But in the false labor pain, it is irregular and it is continuously happening. Remember, true labor pain will not happens continuous. It will be regular and rhythmic. But in the false labor pain, it will happens continuous. But the pain is a mild one in the false labor pain. And in the true labor pain, initially it is mild, then the intensity, okay, and the duration of the pain will increases in the true labor pain. Okay, so then comes to the contraction intensity. Here the increased intensity will be there, increased duration will be there, and increased frequency will be there. As the time progress, the intensity increases, duration increases, frequency increases of the contraction. But in the false labor pain, it will be constant and it will disappear after sometimes, and after giving the rest, after giving the sedation, after giving the enema, the pain will get vanishes. Okay, so then effect with the activity I told. So this false labor pain, it will decreases or stop with rest. But the true labor pain, which is regardless of the movement, regardless of the position, regardless of the enema, regardless of the sedation, and regardless of the rest, it will keeps on increasing in the intensity, duration, frequency. Okay, so it is not having any relations between the effect and activity and true labor pain. Okay, so very important. The cervical changes in the true labor pain, the progressive effacement and dilation of the cervix will happens. Okay, effacement means the cervix becomes shortens and the uptaking of the cervix happens, which creates the proper lower uterine segment. Okay, so the effacement and the cervix will get dilated. Whenever the cervix will get dilated, the length of the cervix become decreases and the cervix will be uptaken. So lower uterine segment, okay, which forms the lower uterine segment. Okay, so effacement and dilation of the cervix will happens along with the true labor pain. But in the false labor pain, there is no any cervical dilation, there is no any cervical effacement. Okay, so very important. The pain location I told, true labor pain starts with the lower abdomen and radiates to the back and thigh. The false labor pain, which will be only in the lower abdomen only. The duration, it is 30 to 45 seconds. The single best answer is the 45 seconds is the best duration of the each contraction, and it is usually shorter and lesser one. Okay, so associated signs I told, in the true labor pain we will get the bloody show. Okay, so that is the mucus tinged blood tinged mucus which will comes out of the cervix when the cervix will get dilate. So that is what we call as the bloody show. This show will not be seen in case of the, okay, show is not associated in case of the false labor pain. Okay, and cervical dilation will not happen and bloody show will be also not available in the false labor pain. Okay, so but in the true labor pain, the bloody show will be there and the membrane also will get ruptures. Okay, so this is the very important difference between the true labor pain and the false labor pain. So this will be very important for your upcoming exam. So hope the concept and the explanation you people would have liked this one. Okay, so yes, if you like this concept, so please do hit the like button. Okay, so here will be the next question which is there in front of you all. Okay, so this is the question which is very important for you all and which requires the somewhat patience to get answer. So please do choose the correct answer. Do read the question carefully, completely, okay, and apply the mnemonic, so it will be helpful for you all to give the best answer. Yes, I'm waiting for your correct answer in the comment box. So please do mention your correct answer here. Yes, the very simple question. Which of the following represents the correct sequence of the cardinal movement of the labor? Yes, which of the following which represents the correct sequence of the cardinal movement of the labor? Option A, descent, then the engagement, then the flexion, then the extension, then the internal rotation. Option B, engagement, descent, flexion, internal rotation, and extension. Then the option C, engagement, flexion, descent, and extension, expulsion. Then the last option, first we have started with the flexion, engagement, internal rotation, descent, and extension. Beta, what is the correct answer? So to remember the correct sequence of the cardinal movement, so here will be a one small mnemonic. You have to remember that one. Okay, so that is the end placer iced. So what is the mnemonic? Already in the previous classes I have told this one. So that is the END, end, FLI, F is capital, L is small, and I is capital. Okay, so that is the end placer iced. Sir, what is it? What it means, sir? First cardinal movement is the EN, that is the engagement. Then the second cardinal movement, what we have is the descent. Okay, so here the fetal head will comes down, so that is the descent. Okay, so the next one is FLI, so that is the flexion. Flexion of the fetal head. Okay, so along with this one, yes, flexion of the fetal head. So after the fetal head flexion, what happens? The C is the crowning. Beta, previously crowning also cardinal movement. Now crowning is not cardinal movement. Still we will consider this one. Okay, it is now not an cardinal movement. So previously this was the cardinal movement. Okay, so next one is the E stands here as the extension. Okay, so head will deliver by the extension. Okay, so how the head will deliver here? It will be delivered by the extension, right? So then after that, D stands here as the delivery by lateral flexion. Okay, so beta, head will be delivered by the extension and entire body will be delivered by the lateral flexion. Okay, so remember this particular important mnemonic. Okay, so first cardinal movement is the engagement, then after that the descent is happening, then after that fetal head is getting flexioning, then after that the extension of the fetal head is happening to get delivered, then after that delivery with the lateral flexion will be there. Okay, so come to the question. So first you have to search where the engagement is the first. Okay, so in the option B and in the option C, engagement is the first. Okay, so after engagement what happening? The descent is happening. Okay, so after engagement descent is happening. Okay, so after descent flexion is happening, internal rotation of the fetal head is happening, then the extension is happening. Okay, so just I have missed here I, right? Yes, after the flexion, so remember here there is the internal rotation of fetal head. Okay, so after internal rotation of the fetal head, okay, the extension, like baby head will be get delivered by the extension, then the remaining body will be, means shoulder and legs, everything will be delivered in the lateral position. Okay, so very important, right? So here are the cardinal movements what you people have to remember in your mind, so it will be very much important. The first one is the engagement. What do you mean by engagement? So engagement is the largest transverse diameter of the fetal skull is crossing the inlet of the maternal pelvis. We call that one as the engagement happened. Okay, so consider this is the maternal pelvis and this is the inlet of the maternal pelvis, or what we can say the brim of the maternal pelvis, and this is the fetal head. Okay, so fetal head, this one, and this one is the largest transverse diameter, that is the biparietal diameter, that is in the a 9.5 centimeter biparietal diameter is there. If this particular biparietal diameter which is crossing the inlet of the maternal pelvis, or which is crossing the brim of the maternal pelvis, I call that one as on the engagement is happened. Okay, so after engagement happened, what happens? You just try to understand the concept here, because from here the question will be arised in your every exam. Okay, so I will explain the concept how actually the labor will happen here. Okay, so I will try my best to clear your concept here, so please do focus here. Okay, so I told the first one is the engagement. Okay, so in engagement, what happened here? The biparietal diameter of the fetal skull, okay, so that have crossed the maternal pelvis. Okay, so now biparietal diameter have been crossed the maternal pelvis, or the maternal pelvis inlet, it have been crossed. Okay, so after crossing that one, now due to the uterine contraction and due to the bearing down effect of the mother, the baby will comes down. Okay, so that is what you call as the descent. Okay, so what is the descent of the fetus? Means the baby is coming down in the maternal pelvis. Okay, so from up it is coming down, means the movement of the baby from the up to down, so we call that one as the descent of the baby. Okay, so whenever this particular baby, it will comes to the down, and at the level of the ischial spine, here there is in the levator animajal. Okay, so here it is the levator animajal. When the fetal head, it will touches the levator animajal, so due to the pressure, it will create the pressure, because from the up the uterus is contracting and the from up the mother is bearing down. Okay, it will create the pressure on the fetus, and oppositely this levator animajal will create a pressure. So due to the recoiling effect of the our levator animajal, the fetal head will flex here. Okay, so fetal head, it will, this particular chin, it will comes near to the abdomen like this. Okay, so this is what we call as the flexion of the fetal head. Okay, so now we have finished with the engagement. There is the largest biparietal diameter which have been crossed the pelvic brim of the mother. Okay, so after that the descent, means the fetus is moves down through the birth canal, so that is what we call the descent, and the flexion. So now the fetal head which attached to the levator animajal, and due to the recoiling effect, the fetal head is flexing like this. Okay, so this is what we call as the flexion of the fetal head. Okay, so very important, try to remember this particular three important cardinal movements. Okay, after the flexion, what happening here? The internal rotation of the fetal head is happening. Okay, so internal rotation of the fetal head will happen. So I told while explaining the ischial spine 4 important golden points. So one thing I told, at the level of the ischial spine, levator animajal is connected. Second point, I told the internal rotation happens at the level of the ischial spine, and the third thing I told, the ischial spine is used for the referring the station, and the ischial spine is used anatomical location for the giving the pudendal nerve block. Okay, so I told the in that one also, among the 4 points, the one point is the internal rotation of the fetal head. Okay, so internal rotation of the fetal head which happens at the level of the our ischial spine only. Okay, so at the level of the ischial spine only, levator animajal connected. Okay, so are you able to focus how I have created the muscles of the levator ani? So it is not straight like this. Okay, so levator ani muscle is not straight like this. It is in a fan shape. Okay, so it is in a fan shape. So like this. Are you able to see the diagram what I have drawn here? Okay, so initially while starting the labor, so fetal position will be at the level of the left occipital transverse. Okay, so after that it will come to the left occipital anterior, then it will comes to the left occipital like not left occipital, it will comes to the occipital direct. Okay, so that is the anterior, right? So from here the fetal head will rotates to till here to get deliver. Okay, so this is what we call as the internal rotation of the fetal head. How it will get delivers, like how it will get rotate means due to the pressure from the uterine contraction and due to the pressure from the maternal bearing down, Okay, so here mother mothers are in a pan shaped, or it is in a it is arranged in such a way that, so if the fetal head is here, okay, so it will rotates the fetal head and it will brings to the center. Okay, so this is what we call as in the a very very important. This is what we call as in the Hart's rule of the Levotrani muscle. Okay, what we call this one is in the, we call this one as in the Hart's rule of Levotrani muscle. Okay, so now the fetal head is, what happened? A internal rotation happened. Okay, so only fetal head is rotated, but the shoulder is still not rotated. Okay, so head is rotated like this. Okay, so out of the 8, this one is the first, second, third. Okay, here it is the right side occipital anterior, right side occipital transverse, and the right side occipital posterior. This is the occipital posterior direct, and this one is the left occipital posterior. So among these 8, only 2 it is rotated. Okay, so it is 2 out of 8 fetal head is rotated, but the shoulder still not rotated. Okay, so whenever the fetal head comes 2 out of 8, and it will get extension and it will get deliver. Okay, so beta, during the normal cephalic presentation, baby head will get delivered by the movement of the extension. Okay, remember the golden point, whatever the thing I am explaining, remember this is the very important. During the normal vaginal delivery with cephalic presentation, that time the fetal head, it will get delivered by the movement of the extension like this. Okay, by the movement of the extension, which first occiput will get delivered, after that the, yes, our vertex it will get delivered, then the brachma, then the brow, then the face, like it will get delivered. But during the breech presentation, first the foot will come out, after the buttock will come out, after that the head it will come at the last in the breech presentation. So that one we call as in the after coming head of the breech. So what we call that one? After coming head of the breech. Why? Because in the breech presentation, leg will come first, then buttock will come, then the body will come, then the shoulder will come, at the last head will come in the breech. So that is the reason in the breech presentation we call that one as in the after coming head of the breech. So in the breech presentation, head of the fetus, it will get delivered by the movement of the flexion. Okay, so it will get delivered by the movement of the flexion. Yes, the golden point of the discussion here is the normal cephalic presentation, the head will be delivered by the extension, and in the breech presentation, after coming head will be delivered by the flexion. Okay, these are the important golden points, just keep in your mind. Okay, so very very important thing I have explained here, right? So now during the extension, the fetal head is delivered. After that, the what happened here? So head is came out. Okay, so I told only head is rotated 2 out of 8, and the shoulder is still, it is like this only. Okay, so now when the head comes out, so that time the shoulder it will get rotates. Okay, and the whatever the here I only head is rotated and shoulder is not rotated, means the head is like this in the position, means the twist have been created here. Okay, so after delivering the head, head will comes back to the normal position. So this is what you call as then the restitution. Okay, so what is the restitution? What is the restitution? So restitution is the untwisting the twist which have been created during the internal rotation of the head. Okay, so during the internal rotation of the fetal head, which have created the twist, so now it is untwisting and which is coming back to the normal, we call that one as in the restitution. Okay, so very very important point, remember. So this restitution, now the baby have come out with the extension, and the now externally fetal head is rotated, and the twist which have created, okay, that is get untwisted now. Okay, so now the fetal head is in normal position. Now the baby will be get expulsed out, remaining shoulder and the back and the foot it will get expulsed out with the a lateral flexion movement. Okay, so these are the cardinal movements of the our very very important labor process, right? So the answer for this particular question goes to the first engagement happens, after that descent will happens, after that the lever-running muscle recoiling effect, so that is the flexion of the fetal head will happens. Then due to the hard roll of the lever-running, means lever-running is in a pan shape, so due to the hard roll of the lever-running muscle, so there will be internal rotation of the fetal head. Okay, so after internal rotation, due to the extension, by extension the fetal head will get delivered. Okay, so the answer is our engagement. Our option B goes to the correct answer. Hope every one of you have understood the cardinal movement of the fetus. Okay, so hope it is clear to every one of you, right? So here is the next question, which is awaiting for your brilliant answer in the comment box. Okay, so along with the cardinal movement, what are the word we have like understood here? So first one we have understood what is engagement. Engagement is the biparietal transfer diameter which have created the which have crossed the brim of the pelvis. That is the engagement. Descent means continuous coming down of the baby in the what we can say in in the maternal canal, birth canal. So baby is continuously coming down. So that is what we call as the descent. And so whenever the baby will turn, so that time it will create the twist. After the baby delivers, head of the baby delivers, so it will get rotated and the twist will get untwist. We call that one as the restitution. Okay. So whenever the baby head is visible in the maternal canal, so whenever the baby head, this is the maternal canal and baby head came like out and it's clearly visible now in the maternal canal. So this is what we call then the crowning. What is the crowning? Crowning is the a visible fetal head in the maternal birth canal. We call it that one as the crowning. So we will do a small surgical incision at the perineum during the vaginal delivery. So that is what we call the episiotomy. Okay. So when we have to do the episiotomy should be done after the crowning only. Okay. After the fetal head is clearly visible in the perineum, then only we will do the episiotomy. Okay. We will discuss that concept also here. So very, very important. Keep in your mind, right? So crowning we have covered, restitution, descent, engagement, internal rotation, external rotation. Okay, so how the normal vaginal delivery, fetal head will be delivered by the extension, and in the after coming head of the breech will be delivered by the flexion. These are the very important golden point we have discussed here. Okay, and the heart rule of the liver training muscle also we have discussed here. Okay, so that's the very, very important point, right? So the next question is here in front of you all. So please do read the question carefully, completely, and give the best answer in the comment box. So I'm waiting for your answer here. I'm waiting for your answer here. Fatafat, do comment the correct answer in the comment box, bachcho. Throat is still recovering, so don't want to damage. So I will take the class slowly now. Okay. So, right. Which type of the episiotomy is most commonly associated with a higher risk of the extension into the anal sphincter? So this one is our question. A very important. In which type of the episiotomy there is highest risk of the involvement of the anal sphincter and highest risk of the tear of the anal sphincter? In which episiotomy there is highest risk? So please do mention your comment, your answer in the comment box. Fatafat. Right? Option E, mediolateral episiotomy. Option B, lateral episiotomy. Option C, midline or the median episiotomy. And option D, J-shaped episiotomy. Yes, almost all you people have given the correct answer. So that is the midline episiotomy or the median episiotomy is the episiotomy where there is the highest risk of the involvement of the or the tearing of the anal sphincter will be there. Okay. So remember, how sir? How means? Let me draw one diagram here. So this is your perineal body. Okay. And here will be the birth canal, and here will be the anal sphincter, right? So whenever we are doing the normal vaginal delivery, if the mother perineum is the very tight, very rigid, or if the baby head is very big in the macrosomic baby and in the cephalopelvic disproportion, the baby head is big and which is not coming out easily. Okay, so in these particular situations, we have to go for the episiotomy. But episiotomy is not routinely recommended by the WHO in a few conditions like the very rigid perineum where the outcoming of the fetal head is not possible, or in case of the cephalopelvic disproportion where the head of the baby is large and which is not coming, and in case of the macrosomia. So in these particular situations, we are going for the episiotomy, means we are taking the small surgical incision at the perineal area to deliver the fetal head and body easily. So that is what we call as the episiotomy. Okay. So now, if I am taking an incision like this, so this is what I call as in the a medio, means I have started from the middle and I have came side. So that is the medio lateral episiotomy. Okay, so which is Usually this is the midline one. Okay, so usually this is creates a degree of the 45 to 60 degree. Okay, so it will create usually a 45 to 60 degree it will create here. Okay, so very important to remember. Now if it extends due to the pressure, if it is extending means it will tear like this side, it will not involve the anal sphincter because this one is the anal sphincter. But if I take incision like this straight means this is what you call the midline episiotomy or the median episiotomy. Okay, so what I call this one as in the midline or median episiotomy. If this particular midline or the median episiotomy due to the pressure, the surgicals like incision, if it is extending means, so it will get involved the tearing of the anal sphincter and it may get tear the rectus also. Okay, so that is the reason never ever recommended will be our midline or the median episiotomy is not usually recommended. Okay, it is not usually done, and this particular mediolateral episiotomy is the recommended one. Okay, and along with this you have to remember the other very important things. If I am taking the incision at the lateral side means here the more muscle will cut. That is the reason in the mediolateral episiotomy the healing will not happen fast. So healing will be delayed here and pain will be more here. Okay, and the bleeding will be more here in the mediolateral episiotomy. If I am taking the incision in the midline, that time the like less muscle will get cut. Okay, the less muscle is getting cut means the less pain will be there, the fast healing will be there, the less bleeding will be there. But the main disadvantage of the midline is that it may get a damages the anal sphincter. That is the very dangerous situation. So that is the reason we will not recommend the our midline episiotomy. Other than that, the midline episiotomy is good. Okay, it is having the fast healing, less pain, okay, less dyspareunia. Okay, so it is having the less bleeding also. So midline is best, but it is having the disadvantage of the damaging the anal sphincter. So that is the reason it will be not recommended and it is not best. Okay, so now the mediolateral, it is having the more pain, more bleeding, okay, delayed healing. Still, it will not involve the damage of the anal sphincter. So that the recommended one is the mediolateral one. Okay, so that is the reason, very important. Just try to differentiate between these two. Okay, already have discussed this point here. Direction of the incision. Please just wait for a second. Yes, so the direction of the incision in the mediolateral episiotomy is the which begins with the opening of the like vagina I told in the center, and it will extend laterally. That is the 15 to 60 degree angle to the midline. Okay, so that is the mediolateral episiotomy. Then in the midline or the median episiotomy, it will starts from the vaginal opening and goes straight down. Okay, so towards the anus. So it is going towards the anus means it will easily damage the anal sphincter. Okay, so there is a highest risk. There is highest risk of the extension into the anal sphincter and damage to the anal sphincter. So that is the reason the midline episiotomy is not recommended, right? So in the mediolateral episiotomy, it is having the lowest risk of the extension into the anal sphincter. So that is the reason the mediolateral episiotomy is recommended. But easy to repair one is the midline one. Okay, so easier to repair and clean incision will be there in the midline. Here in the mediolateral, it is difficult to repair and the angle of the tissue will be more involved because we are taking the cross cut. So that is the reason the more tissue will get damaged, more bleeding will be there, more pain will be there, more time is required for the healing. Still, we will do the mediolateral because for the only one reason that it will not damage the anal sphincter. Okay, so post-operative pain usually less painful is the midline one, and may cause the more painful one is the our mediolateral one. Still we will do the mediolateral because it will not involve the anal sphincter, right? So healing time, long healing time is required for the mediolateral episiotomy, and the short healing time is required for the midline one. So still we will do the mediolateral because it will not involve anal sphincter. Yes, hope the concept is clear. The bleeding risk will be higher in the mediolateral and the lower in the our midline So still we will do the medial lateral. Why? Because it will not involve anal sphincter. Okay, so only one reason I have explained 3-4 times, because it was important, and this particular table is very important for your upcoming exam. Remember. Okay, so hope the concept is very much clear to every one of you. So this is the image based questions they must tracks in your exam. So this is the episiotomy seizure. Okay, this one is the episiotomy seizure. Are you able to see the end portion of the seizure? So this one is the blunt. Both end portion of the seizure are the blunt. Okay, so the end of the seizure will be blunt. So recently asked question. Okay, so here, and it is having the like, are you able to see the like structure? It will be very easy to cut the like our perineal muscles. Okay, so that is the how it looks like a episiotomy seizure. Okay, so very important image based question for the upcoming Norcet exam. Okay, so the next, which type of the anesthesia will be given during the episiotomy? Yes, we will give the local anesthesia here. Okay, so no general anesthesia required. Okay, it will be done under the local anesthesia usually. Right. The second point is WHO does not recommend the episiotomy in all female who is undergoing the labor process. Okay, so episiotomy will be done only in case of the I have told like indications. Okay, so WHO does not recommend the episiotomy in all the female undergoing the labor process. Okay, episiotomy will be done only when there is in the difficulty in the delivering the shoulder. So that is in case of the shoulder dystocia you have to do. Okay, so if the perineum is very rigid in the like primary gravida, first time she is pregnant and she is a parturient now. Okay, so she is on the labor table now, her perineum is very tight. Okay, so there is the perineal rigidity in this particular position. We have to go for the episiotomy. Other than that, if you want to do the instrumental delivery, okay, in the instrumental delivery, episiotomy is compulsory in the instrumental delivery. Remember. Okay, so then after that, if your baby is macrosomic, means big baby which is more than 4 kg. Okay, then we will recommend the episiotomy. Okay, so other than that, there are the very few indications for the episiotomy, but episiotomy is not routinely done in all the females. Okay, not routinely done in all the females. Only in this particular situation we have to do the episiotomy. Okay, so at what time? What is the time to do the episiotomy? When we have to take the incision? Yes, when we have to take the incision. When means after the crowning. Okay, remember, episiotomy will be done after the crowning. So what do you mean by crowning? I have already just explained. When the fetal head is clearly visible in the maternal canal, then only we will do the episiotomy. Till that, there is no need of the episiotomy. When the fetal head is clearly visible in the maternal canal, maternal birth canal, so in that particular situation only we will do the episiotomy. Okay, so other than that, there is no need of the episiotomy. Hope all the golden points on the episiotomy is very much clear to every one of you, right? So here is the next question, so which is very important for you all. So please do read the question and do the best answer in the comment box. So I am waiting for your answer in the comment box. Just now try to give the best answer. Yes, in the high risk pregnant woman during the first stage of the labor, how frequently should the fetal heart rate sound should be monitored according to the standard guidelines? Okay, so according to the standard guidelines, okay, so in the high risk pregnant, okay, in the first stage of the labor, how frequently fetal heart sound should be monitored? How frequently fetal heart sound should be monitored according to the standard guidelines? So fatafat, do mention your answer. Option A, 15 minutes. Option B, every 30 minutes. Option C, every 60 minutes. And option D, continuously with electrical fetal monitoring. So which one is the correct answer? In the high risk pregnancy, in the first stage of the labor, so how frequently we have to do the fetal heart sound monitoring? Remember this particular chart, beta. This is the very important for you all. This is the very important chart for you all. Okay, so in the stages of the labor, this one is the first stage of the labor. Okay, in the low risk pregnancy, we have to assess the fetal heart sound every 30 minutes. In the high risk pregnancy, in the first stage of the labor, every 15 minutes we have to assess the fetal heart sound. So this is the question they have asked in the particular question. Okay, so in the high risk pregnancy, that is in the first stage of the labor, so we have to do the fetal heart sound assessment every 15 minutes one time. Okay, then comes to the question in the second stage of the labor. Okay, so here if it is low risk pregnancy, we have to assess for the every 15 minutes. In the second stage of the labor, in the high risk pregnancy, we have to assess the fetal heart sound every 5 minutes one time. Okay, so very important. Do remember this particular chart. Take a screenshot. Okay, so otherwise make a note of this one. Practice at least 2, 3, 4, 5 times, so it will be helpful for you all, right? So the next question is here in front of you all. So do read the question carefully, completely, then try to give the best answer. Which of the following is an important aspect of the perineal care for a patient after the episiotomy? Yes, this question is the repeatedly asked question and the important question. Post episiotomy nursing care or the post episiotomy perineal care. So very important concept. Yes. So which of the following is the important aspect of a perineal care of the patient after the episiotomy? Option A, avoid the cleaning the perineal area, allow the natural healing. No beta. Perineal area should be clean twice daily with betadine. Okay, so how we have to clean? So we have to clean the perineal area, that is in the, this is the perineal area with vaginal. Okay, so here we have to cover this one, we have to clean this one from the up to down motion. Okay, how the swab will be moved? Okay, so betadine like so-called swab will be moved from the up to down. Okay, like this, right? So this will be a direction of the cleaning the perineum in the episiotomy care. Very important. Why? Because in the down we have the anal sphincter. If you are come down to up means it will contaminate the wound. So that is the reason. So always come up to down. So don't go from the down to up, because it will again contaminate the wound and it will infect the wound. Okay, so that is the reason. So option is telling avoid cleaning perineal area to allow the natural healing. No, it will not heal naturally. We have to take care of that one, because the perineal area is the contaminated area, so which is near to the anal canal and it is near to the urination area. So that is the reason every time whenever the mother will go for the defecation and every time the mother will go for the urination, that time it should be cleaned. Otherwise it should be cleaned every time twice a daily. Okay, with the betadine. Okay, so very important. Then comes to the option B, apply the heat pack directly over the sutures continuously. If you are applying the heat pack directly over the suture continuously, so it will increases the blood vessel supply and it will increases the risk of the bleeding. Okay, increases the risk of the bleeding. So you can do this one for the wound healing promotion, but you are directly applying the heat pack over the suture means that is not recommended one. Okay, so it will increase the risk of the bleeding. I am eliminating the option B also, right? Then comes to the option C. Okay, so here encourage the warm sitz bath to promote the wound healing and comfort. Yes, the warm sit bath will be recommended to promote the wound healing. Okay, and to promote the comfort and to relieve the pain. So warm. Okay, so not hot. So it is the warm sitz bath will be recommended to promote the wound healing and comfort. So this will be the correct answer. Option D is telling avoid the intercourse for the 1 year. No beta. So just we have to recommend to avoid the intercourse for the duration of the 6 weeks. Okay. So how much length should a mother underwent for the episiotomy should avoid the intercourse after the episiotomy? Yes, after episiotomy, she should avoid the intercourse for the duration of the 6 weeks, or we can say 1.5 months. Okay. So 1.5 months or the 6 weeks is the recommended time she should avoid for the very important intercourse after the episiotomy. Remember, so answer for this question goes to the option C, that is the encourage for the sitz bath and promote the healing. So this will be our correct answer. Hope it is clear to every one of you, right? Right? Is that clear? Well done, beta. Very good. So the next question is here in front of you all. So this is not question. So please understand, this is the scale. So we call this one is in the radar scale. Okay. So this radar scale we will use to assess the wound of the episiotomy. Okay. So here we have taken the so surgical incision and here the sutures are there. Okay, so now I am assessing this particular wound by using the scale that is called as the reader scale. Okay, in the reader scale, the R stands here. We have to check for whether any redness is there in this particular area. Okay, so E stands here whether any edema is there. Okay, another is the whether any ecchymosis is there, means any blood is collected, which indicates that there is in the perineal tear, which indicates there is in the intra like perineal there is a damage. Okay, so then D stands here, any pus, any discharge which is coming from here, that one we will check here. Okay, then the last A stands here is whether the wound is appropriate or not, whether any other like opening in the wound will be there. Okay, or any sutures are opened here. So like that we will assess here. Okay, by using the reader scale. R is the redness, E is the edema, another is the ecchymosis, another and the D is the discharge, and the A is the appropriate or not. Okay, so this particular reader scale is a tool we are using to assess the healing of the perineal wound. Okay, especially in the episiotomy postpartum woman, we will use the reader scale. So this will be our important again concept, right? So hope it is clear to every one of you, right? So I am not leaving any single point of the discussion behind. Okay, so this was the class what we have discussed today in this particular session. Okay, so hope you all enjoyed this particular class. Okay, so in the next session we will again discuss the very important stages of the labor. Okay, so after that I will finish the class. I told in the next 3 class OBs will be finished, and after that we will discuss the a very important concept on the pharmacology and the important medical surgical nursing. I will give the 3 short on each very important like medical surgical concept. Every system 3 classes I will finish. Okay, so very important. I will not let your any golden point to get behind. So all you people have to be connected, be joined. Okay, be engaged and watch the class continuously, completely. And wherever the thing I have told, like it is important, at least do practice it one time, because it will directly strikes in your exam. Okay, so hope you people have been enjoyed this particular class, and in the next session we will discuss a very important concept again. And the very important thing what you have to do here is at the end of this class is the that is your assignment again. Okay, so assignment question. Question number 1. After episiotomy, intercourse will be postponed or the intercourse will be avoided till what time? Okay, after episiotomy, intercourse should avoid till dash duration. Okay, just mention the 1. Okay, in front of that you mention your correct answer. Okay, so then the question number 2, so that is a very simple question. Okay, so reader scale used in dash condition. Okay, so other than that, the very important again one more question I will give, so please wait. Right, so that is the level of epidural analgesia injection, epidural analgesia injection in painless vaginal delivery is dash. So please do mention your correct answer. Okay, so these are the 3 important assignment for your today's class. Okay, so whoever watched the class till the end, so please do mention your answer in the comment box, so it will be helpful for others to get revised. Okay, so I hope every one of you have enjoyed the session, and if any one of you are searching for the a good test series for your upcoming Norcet, and if you want to practice the real-time exams for the Norcet, so please, here the master nursing classes is presenting the super 60 test series. Okay, which is live from the morning 6 a.m. to the 11 p.m. with the real time, scenario based, situation based, practical based, fact based, important, extracted, and a selected question discussion for your a very important exam. So where we have given the questions for your selection in the Super 60 test series. Okay, if you want to become a part of that one, so please do download the Master Nursing Classes app. So link is there in the comment box, link is there in the description box. Okay, so happy learning. Thanks for watching the class till the end. Don't forget to share the class with your friends, so that will be helpful for us to build our community. Okay, so thank you so much for the watching the class. So we will meet again in the tomorrow session. Don't forget, there is 50% discount is going on the Super 60 test series. Claim the offer ends. Okay, so claim before the offer ends. Okay, thank you so much. Jai Hind, Jai Bharat. Take care. Love you all. Bye bye. Happy learning. All the best.